Welcome everyone to today's webinar. I am Emma Goodman with Becker's Healthcare. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. We are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email that you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Nader Fahmy is the Chief Executive Officer of National Medical, the leading revenue cycle company in the ASC market. National Medical handles the revenue cycle for over 250 surgery centers in over 40 states. Prior to National Medical, Nader was the co-founder and president of Ajuba International, a leading healthcare revenue cycle outsourcing company that was created in 2001 and grew to approximately 2,000 employees by 2009. Prior to Ajuba, Nader was an investment banker at both Merrill Lynch and Dillon Read & Company. Nader is currently on the advisory board of Resource Pro, which is one of the fastest growing BPO companies and the recognized leader in insurance process outsourcing services. Nader is also actively involved in leading industry associations. Finally, he was named by Crain's Business Magazine to its 40 Under 40 list and was a finalist for the Ernst & Young Entrepreneur of the Year Award. We're also pleased to have Lisa Rock here with us today. Lisa is the president of National Medical Billing Services since 2003 and has over 30 years of experience in the healthcare industry with expert knowledge in professional practice management, ASC coding and billing, and payer contracts and analytics. Lisa leads the largest revenue cycle management company in the country, specializing in ambulatory surgery centers and their affiliated surgeons across the nation. Lisa is listed in the St. Louis Business Journal as Most Influential Businesswomen in St. Louis in 2016 and named as one of the Small Business Monthly's top women business owners for 2016. Lisa was also recognized in Becker's ASC Review for Women Leaders to Know. At this time, it's now my pleasure to turn the floor over to Nader to begin today's presentation.
Great, thank you so much. We're really excited to be here, and our focus on today's conversation is going to be discussing narrow networks, bundled payments, and price transparency. And as you all may know, narrow networks have existed through the years in numerous shapes and forms, but they're really emerging today again in yet different variations, and we'll be discussing that. It's also important to understand the language that may be showing up in your contracts these days so that you understand if you are in fact dealing with narrow network patients. And finally, the bundled payments are really the fastest growing individual form of new payment and really projected over the next 5 years to continue growing. So we'll be discussing that as well as the trend toward price transparency laws. So with that, I'm going to turn this over to Lisa for a bit.
Okay, thanks, Nader. Really, narrow networks have been around for a very long time. From the old country doctor that had his network of specialists in hospitals that he would or she would refer patients to. And then it evolved to the health maintenance organizations, and that was really about cost containment. And what happened with those narrow networks, we all know, is that with the $10 copay, utilization went through the roof, and so had to get our arms around the utilization. So then we came up with different scenarios and organizations, PHOs, managed care organizations, and then evolving to centers of excellence. Today we're seeing those same types of narrow networks along with employer direct contracting, which we're going to talk about, tiered categories that are not only applicable to the exchange products, but we're also seeing those in a number of self-funded plans, and it does affect your reimbursement, so we'll get into that in great detail.
And Lisa, just to jump in on that, there's numerous examples of Lowe's, of CalPERS, of Safeway, different organizations like that, but specifically Lowe's selected the Cleveland Clinic as one of their centers, as their center of excellence. And for example, to show the impact and what's driving and changing behavior in terms of where to go for your health care. Their plan has a $1,000 deductible, 20% coinsurance, and actually from a family standpoint, an $8,000 deductible if you go outside of the Cleveland Clinic for your services. However, if you go to the Cleveland Clinic, there's actually no cost sharing at all for the patient, plus they pay for your travel and the travel of a companion. So that's one example of that center of excellence type of narrow network that really is impacting behavior, and in a large way, Lowe's has 17,000 employees.
I think I want to add to that, Nader, that as the birth of HMOs came around, and we had this incentive to get well with these $10 primary care co-pays, we're sort of coming full circle from high deductible health plans to incentivizing the patients again to go to these narrow networks. And I'm assuming that we're probably going to see an increase in utilization again. It's funny how things are cyclical.
Lisa, back. Did you hit on all those? Yeah. So, further that, as we mentioned, the narrow networks today really are growing. The primary driver of this is cost containment. Surgery-related costs are 30% of the total U.S. healthcare spend, and 82% of employers that have over 500 employees are self-funded. So the employers actually have a very large and significant voice now. And as we all know, the cost of healthcare has become exorbitant from an employer perspective. So employers are looking and pushing for ways to reduce costs. At the same time, outcomes and quality are of course important. They want to provide a great benefit to their employees and create a more administratively efficient process, less bills, less confusion. And so employers have a great interest and desire in the narrow network approach because it's bringing their costs down. We've seen ranging, various ranges, but you're talking 15 to 25% of what's a very large spend for these organizations. At the same time, you have the patients that if you look at the example I gave at Lowe's, first of all, they partnered with the Cleveland Clinic, which is a phenomenal organization. So there's no quality issue from that perspective. And in this scenario, they have no costs and they're having their travel paid for, as opposed to paying up to $8,000 that year in terms of a deductible. So very attractive from a patient perspective as well. And the payers obviously always interested in reducing costs from that standpoint. So there's another part which we're not really addressing here, but providers are, it can cut both ways. You can look at it as a lower reimbursement, but there's also an opportunity to gain increased volume if handled correctly. And finally, it's interesting as we kind of talk about the employers. 29 states self-fund all their health plans, and 48 currently self-fund at least one of their health plans. So the self-funded market is growing extremely rapidly, and the payers actually, I think we're at roughly 60% of their business now is administrative services only business versus paying their own claims.
And if we go to the next slide, we can talk about how you identify these patients and the networks that they're in, and you want to, because your surgery center could be out of 3 tiers, a tier 3 surgery center or tier 3 surgical practice. And what that means for the patient or the employee is that tier 3 would have a higher coinsurance. And so the patient is incentivized to choose a provider in the tier 1 category, where many times the copay, coinsurance, deductible is waived. And there are many reasons for this, but the employers are setting it up this way with the help of ASOs to, of course, contain costs, and they also add to help improve quality as well. So how do we identify? Many providers don't know they're in a tier, or they don't know they're excluded from a tier. So the first thing that you want to do is train your staff. You're going to run an eligibility report, and that eligibility report will show you which tier you fall in, and what the patient's responsibility will be according to the different tiers. And then you want to call for benefits as well. This is a lot of work on the front end, but today, more important that you do it yourself more than ever. And I know that many surgery centers in the past have relied upon the information from the surgical practice. I would not advise that today in this environment. This is a very fast-growing model. So the insurance verification piece will identify the tier structures most of the time, and give you other narrow network information. Now, it's critical that you identify this, because in numerous narrow networks, and we're going to talk about this a little bit later, you may be participating with the carrier, but you could be excluded from the narrow network. And so if you're not doing due diligence up front prior to surgery and finding this information out, you're going to treat the patient, the claim's going to adjudicate, it's going to pay zero, your folks are going to try to appeal it, and you can't because your docs aren't credentialed. Then you go to get credentialed and you find out the network's full and they don't need you and you can't get in. So some place you're going to have to get on top of this cycle to stop it from happening. In addition to being excluded from the network, you could be included in the network. Maybe your net revenue per your contract is X, but the narrow network is not, or explained earlier, is contracted at a lower rate. And so for specialty programs such as the state employees, many times they're in these specialty programs through the ASO, they're contracted at a lower rate than your regular contracted rate. And so your revenue will be off. And again, you may be trying to appeal something that's not appealable. So this is the point where you're going to identify the narrow network patient and what the benefits are, and then get your arms around your patient population. So this is an example of narrow network language that we're seeing today in managed care contracts for surgery centers. And as you can see in the first paragraph, the company reserves the right to introduce your participation in these certain specialty programs. In addition to that, in the second paragraph, they also reserve the right to exclude you from these specialty programs. So this is the type of language that you want to look for today in your amendments, in your contracts, and in all of them, and discuss with your team how you're going to manage this. Maybe it's impactful, maybe not. And then also the company may sell or lease or transfer your agreement to other plan sponsors. And so these are all policies and procedures that will absolutely affect your bottom line. And so I think it's the introduction of these specialty programs, and we see a lot of it with the state employees, where a state employee is coming through your office and they have a major carrier on their card, but they're in that specialty program, and if you're not getting the authorization and finding out at that time prior to service that the patient is authorized to come to your facility or not, that's sort of the critical point where you'll find out whether you're in this network or not in the network. And again, What you do about it then is up to you, whether you call and try to get in the network or try to watch this language to protect your facility.
Yeah, and Lisa, just another point is that this sort of language is emerging in standard contracts today, when in the past it hadn't necessarily. So definitely, as you're negotiating new contracts or looking at your own, you should certainly look at them to understand if it's there, in a draft contract, and work with your counsel to negotiate it to a place where you feel comfortable having it either being in there or modified, more notice, some ability for you to, have some impact or decision making in the process as whether you're participating. So this is negotiable, but not if you're not paying very, very close attention to it. And then once it's in here, it's in here.
And it may not be exactly like this. So, for example, I worked for a Payor 25 years ago, and we had similar language to this to protect our introduction of new CPAs and unions and things like that. And so it could be old language that could be used today, but for a very different reason than what you thought it was for. Additionally, in the narrow network environment, we have language, and this has always been the case, but so prevalent right now because of the movement of self-funded plans. The carrier is letting you know in the contract that they are responsible for paying claims on fully insured patients. But they're also putting in the contract now they have absolutely no legal responsibility for payment of claims that are due from employers. So, or in other words, the self-funded plans. So even though they are an ASO, an administrative services only model, they'll process the claim, but they're not going to guarantee payment. So if your folks are appealing to the carrier and they're not actually the ones paying the claims, then it could be a fruitless effort there. So understanding up front when those patients come in, whether they're fully insured or self-funded, is key. I'm recommending now that people in this industry add a new financial class, which is self-funded, so that we can identify those patients for reporting purposes and also for the tracking of certain employer groups. And also with the employer groups, it's difficult to track them in your software management systems because where you add that information, it's free text. So I would recommend going to your EDI, your electronic data interchange reporting, and trying to pull employer data from that area until we can get a better handle on this. This slide is interesting. So we're seeing this quite a bit now. This is essentially the managed care company giving you a non-compete to sign is what this is. So the first block, the first paragraph is explaining that the payer may contract directly with employer groups or other entities. The second block is basically stating that you can't. So if you are contracting directly with employer groups yourself, like many healthcare organizations are today, you may want to check the language in your contract, especially the new ones coming out, and make sure that you're able to do that. The carriers acting as ASOs today for these self-funded plans are looking at you if you're contracting directly with employers as competition, and that you're taking away their revenue. A lot of times the structure is a % of the claim that they process, and if those are carved out in any way, they're actually losing money. So, so be looking for this too. We're seeing this more and more across the country.
So with all of that, I guess the big picture here is, what is the impact today of these narrow networks on your surgery center? as we mentioned, cost containment is the key driver here. So in most cases, not in all cases, but in most cases, and you'll want to understand this as well as you can, reimbursement will be typically a bit lower. In addition, there's credentialing requirements that you may have to go through, and additional hoops you have to jump through that you didn't before and you need to be aware of. If you aren't credentialed and have seen patients in these narrow networks, then you very likely will not get paid. So again, very important to understand where you stand.
Hey, Nader, I think that's a really good point. We're seeing some high performance networks, narrow networks that have additional credentialing requirements. And this is sort of new, but it is happening right now across the board. So even if you're par with a carrier, that narrow network could be carved out for, usually with cost containment, it's going to be your ortho, like joint replacements and spine and those kind of high cost, but it could also be high volume, like cataracts. So they're looking for those high quality surgeons to include in their network, or low cost surgeons and facilities to include in their high performance network. Right?
That's exactly right. And that can impact, the reimbursement issue, kind of depending on what narrow network from your own standpoint, and where you fit within that. The high performance networks may be able to negotiate a little bit, better rates by positioning that we have a higher credentialing, standard and such. And this is your opportunity to provide the best of the best to your members, to your patients. In addition, I think Lisa mentioned this before, but you could get excluded from your narrow network from a narrow network without even knowing it. And it's very important, if you think about it, that patients are now being provided information. There's multiple different websites. Payers are developing their own versions of websites. There's outside companies that are getting venture capital funded and such that are trying to develop a kind of outcome quality cost ratings for the organizations. And historically, most of the centers and healthcare providers in general weren't necessarily aware that all of that's happening. It's happening and relatively quickly, but I think over the next few years we're really going to see an increase there. So it's important that where are you rated? Are you a tier 1, tier 2, tier 3? Are you a center of excellence or not? You don't, if your volume's going down, you may not know why it's going down. You may not be getting rated here and people are going somewhere else and you're not aware. So it's important, I think, to be proactive and understand where you're rated, and then secondly, what do you need to do to make sure that you're rated appropriately so that it's beneficial from your business standpoint.
What's interesting about that, Nader, is that for at least 25 years, payers have been compiling report cards on facilities and surgeons, and primary cares for that matter. And the difference, though, today is that they're actually doing something with it in terms of reimbursement. So I would today ask major payers for my report card so I can see how I'm being viewed. And because that information is definitely being passed on to employer groups and to the patients.
Yeah, and I think it's important, again, depending on the organization. I was at a national conference and listening to a well-respected organization that provides a lot of this, at least theoretical transparency, and the discussion was ranking people on excellent, good, not good, green, red, yellow, etc. And when you dove a little deeper, 100% of the definition in that scenario was cost, what they're charging. And so also important to understand that is that, outcomes are harder to quantify today. And so some of these things are being driven purely by cost. So again, understanding, how these rating systems work are important as well.
Well, and if you get your report cards, perhaps you can look at the information and provide feedback to the carriers as to why your numbers, if they are high, if you're an outlier, maybe you're in a population with a high cancer rate or whatever it is, and so you can explain why it is what it is. But I think you have to have that information in order to do that piece of it.
With respect to narrow networks, which we're going to get into in a little bit more depth, with bundled payment arrangements, we're going to get into in a little bit more depth. But the narrow networks, in many cases, are starting to utilize the bundled payment arrangement structure, and so it is. And again, we're going to get into the bundled payment discussion in a bit, but it's very complex, and you need to be prepared as to how to handle that from all aspects of pricing and allocating and understanding how that's all going to work. And I believe I mentioned very briefly earlier, there is, again, a flip side to that. There is the potential to really benefit from these networks. You get in a high performance network where people are driving business to the Cleveland Clinic, is getting all of the Lowe's business. I believe it's Anthem is getting a ton of the business from CalPERS. So there's ways to leverage this, that significant volume and good volume is driven your way. And so thinking strategically about how to be on the front end of this is an opportunity for facilities and providers as well. So moving on to, there was, I guess, a decent segue right into the bundled payments. And, today, again, we mentioned that there's really a growing movement here, and 97% of health plans and hospitals have some combination of value and fee-based. It doesn't mean it's all bundled payments, but bundled payments are the single fastest growing value payment structure of any of them. And it says here will account for 17% of all reimbursement in the next 5 years. So very important to understand what it is, what's coming as we flip to the next slide. What is included, what is a bundled payment, what's there. Typically it's a surgical episode on the data service, the surgical fees, physician assistant fees. Essentially everything, it's listed here, but everything, all the ancillary services, your physical therapy, and everything that kind of happens during your global period, and any fees associated with that episode of care. So, there's different ranging time frames. I would say 90 days you often see, for example, in an orthopedic, setting, you have a knee replacement, all of those costs are generally included, in that time frame. So again, they'll range, depending, but it covers everything. And as you can imagine, that creates, significant complexity in terms of how to go about handling, those bundled payments.
Also, with the bundle, as you're working with the various payers and employers, you want them to clearly define the bundle, not to be confused with edit bundling, which is different. This is about containing cost. It's also about patients receiving one bill instead of ASC, anesthesia, lab, radiology. They're getting pathology. They're getting a ton of bills, sometimes 2 years later, and a lot of times they're not even right. And that's something else to note. The quality of coding is going to be critical today, because as these carriers start bundling and profiling, you want to make sure you're being profiled correctly. So what goes out of your practice in your surgery center should be as accurate as possible. But you want them to define exactly what the bundle is. It could be just the implant and the ASC and the Pro. It could be everything here. It could be the entire episode of care. And guess what? These bundles aren't new either. For many, many years, going back to cabbages, and including the entire episode of care for a cabbage in the hospital is something that's been done for a very long time in order to contain costs. So it's just that it's expanding. And with that expansion, if we go to the next slide, what we're seeing today is a number of these outsourced bundling payment companies emerging. And so what's happening is the employer groups and the large carriers are contracting with these folks, and they're carving out, it's a little bit different than narrow networks, they're carving out high-cost surgical cases, and they're basically saying, okay, bundle payment company, you deal with my spine and my ortho cases, at least maybe the top 10 for each of those categories. And so if you have a contract with a major carrier, you could potentially have language. I'm going to just jump to the next slide so I can show you what that language looks like. You could have language like this. This is from a major carrier contract, a bundled payment agreement. ASC acknowledges that it's party to an agreement with a bundled payment company. Therefore, we agree to accept whatever those rates are, and it's a separate contract with that company, and that company must contract with every provider in that episode of care in order for the bundle to work. If you do not contract with the outsourced bundle company for said procedures, then the payment will default to maybe it's a much lower rate than your contracted rate. We're seeing about, I don't know, 90 to 110% of Medicare is a default rate for the carrier. So we're seeing quite a bit of this, especially on the West Coast, but we're seeing it across the country. It is not very organized right now, but it is in place, and it is sort of working. Everyone's doing this to contain cost, and although it's not pretty right now, it is gaining traction. So if I could back up to the previous slide again, this is actually the bundled payment company language that we're looking at on this slide. And as you can see under bullet number 3, that there are certain members or patients that are excluded from these outsourced bundled payment companies. Typically, we're seeing federal government, HMOs, and patients that have secondary coverage. But for the rest of the world, self-funded especially is the number one target here. We are seeing those, which is the majority, we're seeing those fall into this bundled payment category. And so what you want to do is find out from all of your carriers if they have an arrangement with a bundled payment outsourcing company, and if so, which, and by the way, the outsourced cases are designed by the surgery center. Not by it's designed, meaning customized by the carrier and the outsourced bundle payment company specifically for that surgery center. So it's not one size fits all. Anyway, this is something that you want to look into and just stay on top of maybe every couple of months because it is happening today.
And just before we leave the bundled payments, it's very important to understand the complexity of how to go about pricing and processing these bundled payments. So if you think about it, this payment's coming in, and as we mentioned, there's numerous providers involved in that process, so incredibly more complicated than the fee-for-service type of structure where everyone gets paid what they did, directly. And so the level of sophistication and complexity it's going to require, investing in. We're working with somebody who has very complex analytical tools and skills to be able to go through and analyze the median cost of procedures by provider, by particular procedure, by location, to be able to slice and dice that data, evaluate risk, evaluate trends, evaluate outliers within your network that are, doing a particularly better job or a particularly worse job from the standpoint of cost, and working with working to really understand with actuaries to understand the risk. And again, like I said, the allocation of the payment, getting everybody on board with respect to that. So that entire process is quite, as you can imagine, complex. And, there aren't too many people who are doing it or doing it very effectively, today. But anyway, that is something that in this emergence of the bundle payments that it really is important that you understand the actual logistics and execution of that. So, and I guess I just want to make kind of one more example that kind of connects with the entire narrow network and bundle payment before we move on to pricing transparency. And I'd given an example of Lowe's. CalPERS has a slightly different approach to how they do it, but again, similar in that it's impacting the behavior and it's designed to impact the behavior of, of their employees and where they're going to go and ultimately the cost. And so, for example, in a joint replacement situation with CalPERS, they've identified certain designated value centers. And if you go to them, you're treated one way, and if you go outside of that, you're treated another way. And if you give the example of the situation where the charge for that total joint is $50,000 and the allowable is $30,000, if a patient uses a designated center, they owe 10% of that allowable, or in this case, $3,000. If they don't use it, they owe 10% of the allowable, which is $3,000 plus the difference between the charge and the allowable, which in this example, 50 minus 30 is $20,000. So in this case, you can go to one of their designated centers and pay $3,000 out of pocket, or you can go to one outside of it and pay $23,000 out of pocket. Pretty significant
and a no-brainer.
Impact on your behavior, right?
And a no-brainer.
Absolutely. So jumping into our kind of final point here, final topic is the price transparency. And today, in the way we really look at the world, is the patient is now a payer. The patient is its own very important financial class. In the past, patients used to represent maybe 5%, then 10% of your revenue. A lot of surgeons didn't even really kind of want you to bother their patients with collecting them because they didn't want to drive the business away. And that's no longer the case. Obviously with the growth in premiums, deductibles, and co-payments, employee contributions up 83% in the last decade. And as we talked about here today, it's 21% of total revenue, and that's growing. We've seen numbers as high as 30 to 40%, projected from a patient standpoint. And so what's naturally happening? Of course, patients today are shopping. They have to be informed consumers. There's now a lot of movement to provide transparency in pricing, giving them information by which they can actually go out and go online and get a feel for what's pricing. There's Fair Health, there's Blue Book, there's the Healthcare Blue Book. There's numerous other organizations that are popping up every day trying to provide that information. The payers are starting to provide that information. So, again, the goal here is ultimately to provide a fair price to a patient, not surprise anybody. And, the government's getting involved. They've implemented, these surprise billing laws, which are designed to prevent you from getting hit with a surprise out-of-network bill. If you've gone to an in-network, facility and a provider comes in that's out-of-network, you don't know it, you're not aware of it, you may not even be awake at the time when it happens, and in the past you're getting hit with those bills, and so again, the government's getting very involved in kind of consumer protection type of an approach, to help given this real increase in the cost from a individual standpoint. At the same time, when we talk about that, we're still in the early stages. There was a report, 2016 report cut on state transparency laws, and 43 states received an F on their grade. So there's a lot of work to be done here, but it is coming and coming fast.
Nader talked about the surprise billing laws. really every state's working on. But this is an example of one that I thought you might find interesting. This is in California, and so we would see it in the surgery center environment, typically with pathology or anesthesia, and the patient really doesn't meet the anesthesiologist or CRNA until the day of surgery, and they're not asking if the group is in network or out of network. They're worried about their case, and they're being put to sleep, and then they wake up, and then they get a big fat bill and adjudicated out of network. Well, California and many other states have put a stop to that, and if there is an out of network provider, then the provider must treat the patient as if they're in network, and reduce the patient's responsibility as such. But if you go to the next page, they've also extended that to the payer as well. And so, for example, the payer is allowed to pay the average of the reimbursement, or their average reimbursement, or 125% of Medicare. So it's not a situation where the out-of-network provider is going to get that additional out-of-network reimbursement. The patient's bill will be reduced, and the payer's bill will be reduced. And so the provider would be hit with out-of-network benefit designs on top of the payment. So this is not a good situation for out-of-network providers, and this is the type of thing we're seeing move from state to state.
So, you know, there's numerous examples. I think it mentioned briefly that states are encouraging, or even, you know, requiring by law now, price transparency. So this is an example. Florida has been a little more aggressive than others, but others are following suit. And you know, Florida itself has required that there be an internet-based website with all of the information for providers with their pricing, to allow them to make you know, very clear and informed consumer, you know, financial decisions on where they want to go. And you know, again, this is early stage. You know, we just mentioned that a lot of states are failing in their, you know, in their efforts today, but it's early, and but it's coming. And you know, again, Florida's required it by law here, and with that movement, again, there's more information than there's ever been. There's, again, companies that they're being very well funded to start to go out and pursue, you know, this information, pricing, outcomes, overall quality, and provide that information back. So it's going to be a very different competitive landscape, and the providers are going to be, you know, forced to compete in this arena and address it. You know, we've all seen, you know, in different organizations, you know, different ways. You know, you'll see the health grades and such, which are used a little bit Glassdoor in a business context, but all of that's starting to come, you know, and that's more patient satisfaction than it is necessarily outcome and cost, but all of these are sort of starting to merge and come together. It's also important in this concept to understand that the patients, while they're becoming more and more consumers of this, are going to be asking questions of you. So it's important, I think, to have, you know, from your own staffing and your own, you know, thought process from servicing the patient standpoint, to have people on staff who are very well versed, knowledgeable, patient-friendly, and can communicate these points when the patients call, because it's natural. They may look at the website and understand they're probably not going to call the insurance company. They're going to call you and ask questions. So it's important to get, you know, be prepared for that. And again, if done correctly, it can be, you know, this can be all very positive and an advantage. So it can cut both ways, and depends on, you know, how you want to go about addressing it. But I think it's here to stay. And this slide is just an example of what Florida, for example, has. It's their website. So if you want to go throw in, a particular procedure you're going to, have done, you can go on the site, put that in, and then boom, it's going to pop up for you.
Yeah, this is actually a cool way that one ASC in Florida published their pricing information. Yeah. And it's just a wonderful example of them abiding by the Florida State law.
And again, being proactive and churning some of the changes, getting ahead of it, and making it a competitive advantage versus, versus it being a negative. So with that, that really concludes the formal presentation. So to open the floor to questions.
Great, and Nader and Lisa, just terrific, and you had literally nobody drop off through the entire presentation, so just a fabulous job of educating the audience and helping them on the subject. We've got a great number of questions from the audience. Let me dig into those without further discussion. So, Nader or Lisa, in the ASO situation, is the plan administrator typically paid a percentage of the claim, or is it paid a per member per month value? And if a percentage, what's the typical percentage?
Those are all really good questions, and it's all over the place. So you can do a per member per month. You can do a per member per month plus a percentage of the claim. It could be 5 to 9%, even in certain circumstances of the claim. The arrangements are wide-ranging, and I would not be able to answer that question properly because it really is just all over the place. The PMPM and percent of claim are two good reimbursement methodologies that are still being used.
Thank you. And a general question is, and maybe they do, but why don't high-performing, high-quality networks have more control over their pricing, their power in the sort of market? Can they warrant a higher reimbursement rate? Any thoughts on this, Nader, or at least in what you're seeing?
I think they should. I think the problem is that data speaks today. So if you are high performers, if you have legitimate outcome studies and not manipulated outcome studies, but legitimate outcome studies that show your readmission rate, your infection rate, your prescription rate, all of these costs that go into an episode of care. If you're a high-performing doctor, the rest of the world sees you as someone that can one and done. You're doing the surgery and the patient doesn't have to come back again. If you can prove that through data, then I think that you are in a much better position to get a higher reimbursement because of all of those factors that we just mentioned, which would eventually reduce costs. But today, the only thing any of us have to look at is the pricing sheet on the face of it.
Yeah, no, I think that's and Scott, just quickly on this, there is, as we mentioned, very little in the way of these pure outcome companies, but again, they're coming. We're seeing a lot of them, in sort of early stage mode, but we've also seen a lot of studies that show an actual inverse relationship between patient satisfaction with surgeons and actual outcome. And so it's difficult.
It's difficult.
But exactly, to really genuinely judge that, and therefore it's so much easier, and it defaults to, a pricing discussion. And then these high quality providers get into a situation where they're being squeezed and have to decide, do they want to pass on that business or not? So it's a little bit difficult.
So, and a lot of it's just driven by the fact that there's just not enough data sometimes to show that somebody should get paid more for it, and then whether it's really of value to the payer and whether you could negotiate that. So let me go on to a couple other great questions we have here. Question about price transparency. When people publish their pricing sheets and so forth, are those really their rate sheets, their bill charges, or is there something that's closer to what they actually get collected that they publish, or is it really just typically the retail pricing that's published?
It's retail pricing, and you want to publish your case rate if you're an ASC. So you don't want to put the primary procedure up there as $10,000 gross billings when it's actually 5 procedure codes, and it would be right 20,000 or something like that. So you want to put the case rate up there, and you want to put gross billings because that is your charge. And it's important because of the high deductible health plans and patient as a payer. And if you were to publish net, then which schedule would you use? So I think you're better to do your retail pricing.
And Scott, that's actually a really, really interesting and good question. And one of the things that we mentioned in there, if you want to be proactive and have your front desk well versed in this when the questions come in. And so having the ability to give a legitimate, fair estimate to your patients when they call is a big competitive advantage, because many people are weak in that arena and don't have necessarily the tools and resources to do a good price estimation, and some are actually very proactive in that approach.
So this leads to another great question, Otter, and thank you, and I'll ask you, Lisa, to pick up on this. It's how do you train staff to give as good estimates as they can, given that there's so many different contracts, so many different patient responsibilities? How do you work with your staff to give patients as good a good a sense of what they're going to owe and what's going to cost as possible?
Here's the first problem. There's a huge discrepancy between what's actually scheduled and what's actually performed. So we have to figure that out first. And so that we're giving accurate information, we don't want to give the patient an estimate on a single line, and only to find out the surgeon goes in and does 5 or 6 lines, and it's a different look than what the patient expected. So doing a better job of documenting at the time of scheduling what's actually going to be performed is part of it. And then the second part of it is, a lot of training needs to take place today at front desk, not just on pricing, but I really believe today that piece that you just asked about has to go to a financial counselor, someone that does nothing but this all day long. And it's tough for the smaller surgery centers, but this is really what's needed today. Someone that specializes in all the different products and narrow networks and understands the patient's true responsibility is.
Yeah, and I think one last part of that too is that there are, again, emerging technologies that can help. Most are behind the curve, especially in the surgery center market, with being able to provide, again, very good estimates. But again, I think that is something that's coming in some form or fashion.
And here's a related question to that. There's all this discussion about hospitals and surgery centers and physicians moving towards more transparent pricing. Who is that ultimately tailored to? Do you ultimately see this as the patient just going online to get a sense of what their pricing is going to be, or is it at the end of the day it's going to drive people to different places, and how is this likely going to actually translate into, is it going to be a marketing type effort, or how is this going to translate into people buying healthcare services or choosing providers?
I really think, Scott, it's going to be employer driven through these narrow networks. I think that we're already seeing today employers saying, if you go to this hospital, this surgery center, these surgeons, we're going to waive your responsibility. And as a patient, that's where I'm going to go. It's, again, a no-brainer. So I think the employers, given that roughly 50 to 60% of the major plans are carrying self-funded plans through their ASO business, I think that this is something that we have to pay attention to today. I think the employers are going to dominate. They want to control their costs. We all, as business owners, get these pricing increase through our premiums, and they're just tired of it. And so they're trying their best to do their own form of cost containment through employee incentives, like I just mentioned. And with the bundled payment the employee's not going to get a ton of bills that are incorrect and that are expensive. And so I really think that this is my opinion, I think that's the future.
Yeah, I would agree. I also think it's going to be very interesting to see if there are some creative and aggressive, marketing approaches to be proactive, and kind of come at, we've seen it in the MRI world, for example, where you're coming out with a rate and it's a low rate and it's an attractive rate and it's flat and you're marketing and leading with that. I certainly wouldn't be surprised to see that. I haven't seen much of it today, but I could certainly see that now.
People were talking about it a couple of years ago in surgery centers, and you haven't seen that much of it. You're absolutely right. You see the MRI online and some other places where they're actually starting to make an impact. And is it more complex in the surgery center area because you have more related parties to give people a true price? Is that what slowed it down? Or how do you provide a clear estimate? Lisa mentioned this a moment ago about, well, it's not just the surgery center's price, it's the related parties' pricing too. How do you provide estimates that are consistent with the surgery centers that are providing a cash bundle price, or how do you look at some of this stuff?
So there's a lot of work that would go into coming up with a bundled pricing package. So, for example, let's say we're doing a lot of total knees in the surgery center today, and we're going to look at all of the associated costs for that total knee, including any physical therapy, as Nader mentioned, post-operative care. We're going to look at the whole episode of care, and we're going to say, this is $15,000. That's the bundled price, and that includes everything. The payment would go into one location and be divvied up amongst the providers accordingly. And it really is going to be us as providers taking a hard look at the true cost, build a fair margin, bundle it, make it easy, and I think that's really where it's going, because today, if we go into an employer and we ask for a claims run, they can't, and I mean a self-funded employer, we can go to their TPA or directly to them, whoever is housing those claims, and we can ask for a claims run. They're not going to be able to give us all of those associated costs. They don't even know what their costs are, but what we do know is that it's 30% of the healthcare spend, so it's significant. So that's why they're listening and they're kind of latching on any cost-saving plan that comes across their desk.
Well, let me ask you a question. You and Nader have built, if not the absolute premier billing and revenue cycle company in surgery centers for billing and collections, and you work with literally hundreds to, I don't know how many sites today. Where are you seeing the bundled efforts? Are you seeing them more with chains, with individual dominant centers in a market, or just one-off centers that just happen to be ahead of this in a specific specialty? Because I know it's an evolving playing field. Some people are really doing it. Some payers are responsive. Some are not. What are some of your observations on what you're seeing out there today? I mean, you guys have as much experience in this as anybody in the country, so would love to hear some of your thoughts on what's really going on in the surgery center market with it right now.
So we're seeing the major carriers outsource to bundling companies that can process. Really, folks haven't figured out how to process bundles or put them together, as you just described. So you have these companies that are emerging right now, and major carriers, okay, the top carriers that you all know are contracting with these outsourced bundled payment companies for their self-funded plans. And then the second piece is we're seeing employers contract directly with providers, whether it's surgery centers or large physician groups, and bundling the pricing that way. Now, it's not very organized right now, but it is gaining traction. We're seeing companies, large carriers, buy a delivery network for this probable model. And we're also seeing large organizations organize and either deliver a bundling service for the carriers or deliver the bundling service for the employer groups. That's what we're seeing today. So those that are progressive and sophisticated and have a lot of numbers, that's where we're seeing it happen today.
If you're a surgery center, an individual surgery center, is there a way to get out in front of this or partners be in front of this? And do you need to? Should you, or should you just sort of business as usual is going great, just keep at what you're doing? What's any advice, Nada or Lisa, on that question?
I would not do the latter.
She would not do nothing.
I would not be business as usual in this market. I think you have to explore your own region and see what's going on with the narrow networks. That's number one. The bundling payment organizations. I think you need a lot of intel in order to not just survive in this market. As Nader mentioned earlier, Scott, there are numerous opportunities to actually thrive in this market. If you're one of the high-performing surgery centers and surgeons and anesthesia groups, you're going to do very well in this new world. Okay, if you have a surgery center with infection rate problems and mortality problems and readmission problems, you're probably not going to do so well. You're probably not going to do well if your charge master is 25 times Medicare. Okay, so there are wonderful opportunities here for those high performers and those that can prove that the initial cost is actually lower through episode of care analysis. And guess what? You don't even have to do a lot of this work. You can go right to the carrier. Trust me, they've been doing it on you for years. You can get report cards from them, and they hopefully will share them with you, and you can see whether you're an outlier or not.
You got it. Thank you so much. Nada and Lisa, you have made your company over the last decade to 2 decades the absolute leader in this surgery center sort of billing and collecting business. Just have stayed with it, have grown tremendously, have added tremendous resources. I mean, you do, instead of outsourcing, you've insourced into Missouri a lot of your people and just grown tremendously the amount of staff you had. I know you were mentioning on the phone earlier, just hired another 20 plus people and just a great service provided in our sector. Nada and Lisa, can you phone numbers you could leave with the audience so the audience can reach you, and anything that you wanted to say to the audience as we sort of end up and finish up today?
Scott, we've got on the screen, we have a email address, info@nationalisdbilling.com. And I don't know if maybe that's just the easiest way.
I think that's
probably the easiest way.
And questions too. We're happy to answer any questions for your listeners, Scott.
Yeah, because I'm sure we didn't get to all the questions here. So if anyone has follow-up questions that they want to come back to us with, we'd be happy to answer it. But no, Scott, obviously we just appreciate the opportunity to speak today and appreciate everyone that you guys were able to bring to the call for this. And if anyone has any questions, we'd love to answer them.
Thank you so much. Emma will help share with you other questions that we didn't get to, but just a pleasure listening to you talk and your perspective on what's going on in the market. You see it as close as anybody, so we greatly appreciate it. Nada and Lisa will talk to both of you shortly and hopefully see you next week. And thank you folks very, very much as always for a terrific presentation. Thank you.